Mode. Does that look okay?
Yes.
All right. So my name is Jake Mantuffel. I'm a emergency medicine doctor at Henry Ford in Detroit, and I'm also boarded in addiction medicine. And joining me is Dr. Nick Rademacher. I'll let him introduce himself.
Hey, good morning. I'm Nick Rademacher. I'm also an emergency doctor. I work at the Trinity Grand Rapids site, and I'm also boarded in addiction medicine.
And I don't think Dr. Borgiali is joining us today. He had a conflict and he had to drop off. But he is also emergency medicine and addiction medicine provider and a great source of knowledge. So he helped review these slides for today's presentation. And today's presentation is really all about peer recovery and with some emphasis on hospital-based peer recovery because there's all types of peer recovery out in the community. But we're really focused today on this presentation, hospital-based or peers that will be in your emergency department is the focus of today's presentation. And just full disclosure, both Nick and I, and as well as Dominic, are technical assistants for the Community Foundation for Southeast Michigan. However, we do not receive any additional financial benefit from the prescription of medications or treatment of patients. So the basic learning objectives for today's talk, and we'll see how long it lasts. We have 2 hours blocked here, but I doubt it'll go more than an hour and 15. We'll try to kind of chime in with our experiences. And again, please, if anybody has questions as we go, please feel free to interrupt. This is really for the group. We don't want to talk at you, and we're happy to engage with you. So if you have any questions or something's not clear or you just want to chime in, we welcome that as well. So the learning objectives, though, are to define the role of a peer recovery coach and understand the current available models for peer recovery coaches, and also to understand the value of having a peer recovery coach integrated into your department and especially into your EMR. We'll get more into that later. And also to highlight some of the not quite well-defined, but new opportunities in funding available for hospital-based peer recovery. So hopefully that will become more clear in the next few weeks, but we will touch on that as well. So these are kind of our staple slides. We've introduced these at the beginning of each of the talks that we've given so far. I think this is number 5 of 6 in the series that we've put together for Community Foundation with Michigan Hospital Association. And just looking at the statistics, the rapid rise in opioid-related deaths, mostly fueled by the fentanyl epidemic and synthetic opioids. This hasn't gotten any better. It got worse during COVID-19 or during COVID from the COVID-19 virus and has continued to trend higher. So most recently, I've seen the overdose deaths level off, but however, in underserved communities, those actually are greatly increasing. And so there's some health disparities that are starting to show themselves, and a great point of emphasis going forward, making sure that care of opioid use disorder is equitable for patients. And this is my kind of soapbox slide as well, opioid use disorder. Why do we say opioid use disorder? Why don't we call these patients heroin addicts or use kind of other disparaging terms that we've commonly used over time? And it really is because words matter, and that doctors stigmatize these patients, hospital staff stigmatize these patients, and the patients stigmatize themselves. And so we all need to understand that addiction is a disease, not unlike diabetes or any other disease. It's not a moral failing. It's not a personal choice. It's a disease. And we as physicians are trained at this point and have the medications to treat it. So we don't stigmatize our patients or make them feel bad when they come in to the ED if they've got diabetes and their blood sugar is high. We see them, we identify the problem, we treat them with the medications available, and we make sure that they have good follow-up. And really the case for opioid use disorder should be the same. And we're slowly but surely getting there, but recognizing that there is still a lot of stigma out there, and some of it's human nature. But we need to recognize that the stigma is there, and we have the ability to treat these patients and should do so. Another bit of word salad, you may have heard of MAT, or medication-assisted treatments, and the kind of the new terminology that's being used is medications for opioid use disorder, and that is kind of to place the emphasis that sometimes the medication is the treatment itself. And a lot of patients benefit from adjunct therapy and treatments. However, some patients just need the medication to feel better, and can kind of get there on their own time with the support of an ongoing physician care. So first, to define kind of what is a peer, this is just to identify the people in this photo. This is one of our recent graduates on the left of our residency training program, and this on the right is Stan Willis, also known as Stan the Man. He has been our first hired peer recovery coach in Detroit back in March of 2020. And he's been with us ever since. He is beloved within the hospital. He knows everybody. I don't know how. I took him out for lunch the other day, and it was as if he was the mayor of the hospital, just walking through the hallways. Everybody knows him. He's giving hugs left and right. He can barely move throughout the hospital without somebody knowing him and saying hi to him. And we do have a couple other peer recovery coaches as well who do awesome work, but just a shout out to Stan, who's been with us from the beginning of our peer recovery employment program. And so a peer is somebody who is in a journey of recovery, who identifies with individuals or patients based on shared background and life experiences. So these people generally are people that have been are in recovery. And a peer recovery coach is actually somebody who is specially trained to provide those advanced support services, particularly in Michigan. This is from Michigan.gov website. And they work with individuals during their recovery by linking them to the community and its resources. They serve as personal guides and mentors, and they help people overcome their challenges and the environmental and other social determinants of health that might be in the way of their recovery.
Jake, I want to take a quick second
Sure.
to kind of highlight the other things that Dan is offering to your department in your hospital. A couple slides ago, you talked about stigma. And when we started having peers come in, I think one of the things I realized is they weren't just contributing to the patients, but they really were doing a great job breaking down the stigma that everyone held against those with opioid use disorder. Because I think the truth is that people with opioid use disorder, when they're sick, are more challenging to deal with, right? They are irritable, they're demanding, they can be manipulative, and that's all part of the disease that they're suffering from. And so if you go from a setting where the only time you see people with opioid use disorder is when they're in the thralls of their disease and they're not all that likable, you may think to yourself that you don't like people with opioid use disorder. And this is kind of where the stigma builds from, especially in the healthcare setting. And then we'd have these peers come in who were in recovery, who were doing great, and they didn't have any of the, personality or behavior problems associated with opioid use disorder. And I really could feel that some of the stigma held by staff would melt away, and that actually, if we help these people, we may get more stands and fewer of the patients that are causing us a headache.
Yeah, no, that's a great point, Nick. Thanks for highlighting that. And Stan, he has patients that come to him, even when they're like with family members, and thank him profusely. And Stan will bring them to me sometimes and say, so and so is here, and we got them, back in recovery, and they're doing great. And those are really the personally rewarding stories, when you actually get to see it. And I think you're exactly right, is our peers themselves are rewarding stories, and they are kind of the, beacon of what others can do if they can make it into recovery and do well, and contribute to the health of others. So absolutely great point. Thanks for sharing that. So in Michigan specifically, there are certified peer recovery coach actual training, and I think this probably exists in most states. and it's 40 hours of coursework in order to get certified. And essentially covers, this is also from Michigan.gov website, but describing the roles and the functions of peer recoveries, building the skills to do motivational interviewing and brief interventions and enhance relationships with patients, understanding that there are a ton of co-occurring disorders, mental health or otherwise, and the medications involved in treatment, understanding the stages of change that patients potentially go through. And a lot of times our peer coaches will come to me and about a patient that I might have called them on, or just kind of touching base for somebody that they've seen, and they say, well, they're not ready yet. They're kind of termed in pre-contemplation phase, but we've always kind of taken pride in the fact that again, we're starting to break down the stigma. The patient knows that we're here and we're willing to treat them, for their substance use disorder, and they're just not quite there yet. And so we often kind of term that, we've planted the seed, and they know, and sometimes and often they come back asking for those individuals, and, understanding that, they just weren't ready that day. However, knowing that the resources are available is huge. And sometimes they don't just come back to the ED, they will call our coaches and they can arrange for them to get into inpatient or outpatient treatment as needed, without even having to come back to the ED at all. Our coaches hand out cards. Some of the ethics at play they cover, and wellness planning, and then practicing their skills. Generally speaking, peer coaches that you might be hiring into your ED or having work in your ED or have been in recovery for a minimum of 2 years. And that's kind of an important process too. We have to keep tabs on them and make sure they're taking care of themselves. And their level of autonomy can vary. They can engage with patients out in the community in a solo manner, or they might be part of a working healthcare team like they are in the hospital-based system. So I put this on here. This is actually the Henry Ford job description for a peer recovery coach, because this is when we were starting our program. This was like one of the practical things that we needed to challenge. Like, you obviously have to involve HR, and they have to, create a job description and post it and conduct the interviews. So it's pretty basic. It says high school diploma or GED required, basic computer skills, be able to read, interpret documents, and write routine reports like documentation. We have in here 3 years of personal recovery, but frankly, if we had a great candidate, I don't know that we would be strict about that criteria. And so sustained abstinence during that period. And they have to listen. Obviously, that's probably the biggest skill set that they have is, they have the more time than us, but they listen and relate far better than we ever can to patients when it comes to substance use, and also verbal and written communication skills. So be able to work with detailed information, strong interpersonal skills, yada, yada, yada. So essentially, it's a pretty vague job description, but it, kind of emphasizes the personal nature of the work. I just thought I'd share that just because this is, kind of one of the building blocks if you were to go down the path of starting to try to hire your own peer recovery coach. So share this article. This is kind of the why for peer recovery. Or one of the many examples of why we look to peer recovery coaches. And this is a study that looked at a different term, but the same thing, recovery peer navigators, and how they do in treatments when pre and post the implementation of their recovery peer navigator program. And what they found was that they were using a variable known as continuous retention, and these variables can be tweaked or across different studies, but essentially the patients engaged in treatment, and they found that 27% of patients were engaged in treatment before the implementation of their peer recovery navigator program, as compared to 80% of the patients after the implementation of their recovery peer navigator program. So these are patients that come to the ED They go out, presumably with a prescription of buprenorphine, and the presence of the peer recovery navigator in these cases had them in treatment at a far higher level than they were prior to the implementation of the program. And this is pretty consistent in the literature. The landmark paper, which I don't think we have included in this slide deck, was from Dr. Gail D'Onofrio out of Yale. And I think their study was published in 2015. And they found the same thing, that with treatment, their emphasis was more on the provision of medication, but also in the setting of a warm handoff with a peer recovery coach, they achieved about 80% retention in treatment at 30 days.
The biggest takeaway for me for this paper is that while all racial and ethnic groups had improved retention and care, that Black patients had the largest effect, the 73% increase in retention. I think with every presentation, we talk about the racial disparities with the opioid epidemic, and that our Black neighbors are dying at a higher rate than other racial and ethnic groups. And this is, as far as I can remember, the only intervention that seems to preferentially benefit our Black patients. And so I think it's important to realize that this is important for many reasons, but if we're trying to level the field and focus on some of the racial disparities, this seems to be the most effective thing that I've seen.
Yeah, thank you, Nick. Second study, just wanted to highlight here, was another, kind of why are we using peer recovery coaches? And this might appeal to, your health insurers or your C-suite in terms of resource utilization. So this study was published in the American Journal of Emergency Medicine in 2023, looking at emergency department utilization in patients with substance use disorders. And what they found in this study was that by and large, actually, their peer recovery program, if you looked at all comers, did not show any statistical benefit. However, if you looked at the subset of patients with at least one substance use-related visit, there was a large statistical significant reduction in emergency department utilization, and in particular, patients that had 5 or more visits that if visited the ED after the implementation of peer recovery program, they ended up having like a 3.6 visit reduction on average as compared to prior. And I've done similar research. We've given about 14 or 1,500 doses of buprenorphine from our ED starting when we launched our program in March 2020. And what we had found is that there was about a 60% reduction or zero utilization in the patient population before the, I'm sorry, what we found was that 60% of the patients had zero or decreased emergency department visits when they came in the ED and were treated with buprenorphine. And similarly, a 75% reduction or zero hospitalizations. And so I think what this study was kind of hinting at is what we found as well, that when you can't have a reduction if you've had zero visits pre and post, obviously, and so that shows no difference. But in folks that had been to the ED, we were seeing a significant reduction. So I actually like to go back through my data and kind of tease out those that had zero visits and focus on the ones that had 1 or more visits prior. So this is kind of makes the financial case in some cases, or for some people, that there is financial benefit to many in employing peer recovery coaches, and by themselves are not a large financial investment.
Adding a little bit of a background on why that might be, it seems people that have opioid use disorder who use the emergency department more frequently probably have some other psychosocial problems, whether it's lack of housing or transportation, no follow-up. So there's a similar study that kind of quantified what the navigators were actually doing. And so in addition to offering the support and these warm handoffs, making sure they're going to appointments, they helped apply for federal phones. They applied for housing vouchers. They applied for food programs. They got bus tickets for patients. They got vouchers for those without insurance for buprenorphine. Um, and, and they're just doing a lot of other stuff that makes patients with difficult psychosocial situations have better retention and care and require less use of the healthcare system.
Yeah. Thanks, Nick. Yeah, another important reason as to why peer recovery coaches, they do kind of the work that we all know that needs to happen, but they have a little bit more time and expertise to actually make the things happen and to kind of dig down as to why our patients are struggling and what barriers that they are needing to overcome. So that was kind of it for the why. Hopefully we've at least made somewhat of a case that that these are very valuable individuals to have affiliated with your emergency department. And then now we're going to kind of talk about the different ways that they can be embedded or associated with your ED. And the three main ways that exist locally, or at least across the state, are those that are hospital employed, which are very rare, and as far as I know, only existing at Henry Ford Hospital at the moment. And those that are PIHP contracted, which is the prepaid inpatient hospital plan or Medicaid contracted organizations that employ peer recovery coaches and then can thereafter be integrated into your hospital. And then the third major way, at least in the state of Michigan, is nonprofit association or organization, Families Against Narcotics, FAN for short. They are actually a line item in the Michigan state budget, and they can cross county barriers or regional barriers that PIHPs set up and have some unique circumstances around them. And I find them to be a pretty valuable organization, at least in the Southeast Michigan area, but they are continuing to spread. So from the hospital employed side of things, you're going to need to deal with HR and onboarding. But one of the perks is there is quite a bit of ability to track the work that they do because they're your employees, and you can kind of track their documentation footprints and things like that. So, you can start to measure some of the value that they provide for your organization. With a PIHP contracted peer recovery coach, there can be some struggles in integrating them into your hospital, but I highly recommend that you do that if you can, and particularly get them integrated into your electronic medical record. Obviously, a hospital employed peer recovery coaches, it's a bit easier to do that. And then the FAN model has some of the same struggles, pros and cons, as the PIHP contracted model. And we'll kind of dive into each of those categories in more detail here. So the biggest thing for me as a clinical provider, as an ER doc working on the daily, these peer recovery coaches, obviously they can connect with patients better than I can. They, can do motivational interviewing in ways that I am unable to do. I just cannot connect with patients on the level that they can. But the greatest value to me is they know where the patients can go. They know they can navigate the outpatient landscape or inpatient landscape better than anything, or any better than anyone that you might come across, save a social worker. But I think that they may even have, because they have the expertise in the substance use world, that they maybe even be able to do this better than some of your local social workers. Although I know that there is some regional variation, and some folks even use nurses in this for these functions as well. But I'd argue, bang for the buck, peer recovery coaches do it better than anybody. There are different ways that you can refer patients. You can hopefully refer to some of your own clinics. I know there's often insurance holdups with that, and you might have to rely on community resources that will take care of kind of any patient with any medical insurance. One of the struggles that people have with referring out to patients is there are a paucity of physicians that are willing and able to treat addiction, but I would say that cohort is starting to grow. I think family practice in particular, at least in our area or within our system, is a kind of a willing provider that has been asking us, frankly, to start to refer some patients internally and kind of help navigate the challenges that might go with that. There's a lot of benefits to referring to your inside your own system, is you can figure out what percentage of patients are actually attending their appointments, and track who is maintaining care. And I can tell you that after being involved in a larger study with buprenorphine treatment and retention and care, that's a really hard variable to measure. So if you're referring to places outside of your institution, like most places do, and that we do, it's really difficult to try to get a status update on those patients. There's obviously the appropriate privacy concerns, but even if you've got kind of the paperwork that would allow you to get that information, consents and whatnot, it can still be very difficult to actually find out, how that patient is doing after they've left your ED. So some of the pros and cons to the referral process are kind of inherent in that if you're referring outside, you don't have the tabs on the patient like you'd have if they were going to your own clinics. And that would also expand the role of your peer coach, in order to do outreach. Hey, you missed your appointments, or everything okay? Anything we can do for you? In an ideal world, our peer coaches are calling people on the regular basis. They're not just doing the initial ED visit. They're calling, following up overdoses. Maintaining patients at least for a certain period of time through their care. But the reality is we don't have the bandwidth for that at the moment. So hopefully, as these funding systems come into play, I think there is tremendous value in having peer coaches, have some longitudinal care with patients outside of that initial index visit. And there are some other considerations to keep in mind when you are referring out patients. There are, about 40% of patients that have opioid use disorder or substance use disorder suffer from mental health disease as well. And so a lot of these places, particularly community organizations, have co-located services. They'll have both mental health and substance use treatment at the same facility. Tons of our patients obviously suffer from dental issues, and there are often co-located services with dentistry. And then again, the social determinant of housing is huge in this population. And that is something else that can be considered when you're referring out a patient. Anything else you wanted to add to this one, Nick? I kind of beat this one pretty hard.
Oh, you did a good job.
Yeah, okay. Moving on here. So I can speak to the staffing models for hospital-employed peer recovery coaches, possibly better than anybody in the state, just because we have had these unique system of hospital-employed peer recovery coaches since March of 2020. And they are obviously pro is they're your employee. You have significant control over their scheduling. As I mentioned, that tracking their work, in terms of documentation. They are able to document in the chart, and that's, their basic corporate access allows them to access the chart. And we've been able to build templates in order to try to see what kind of interventions they're doing and try to pull reports on that. So there's quite a bit of benefit in the hospital employed peer recovery model that we use. There are, I believe, a significant increase in the number of patient care touches. Whereas if you're having just an outside organization that's either on call for you or embedded but not necessarily integrated, we are our peers are seeing a lot of patients because we've set them up to do so fairly independently, and I'll kind of get into that in the next slide or two. There is increased ability, obviously, to track their interventions and outcomes, as I mentioned. The cons, if you're hiring somebody that has had prior legal problems, possibly related to their substance use, and if they got a felony on their record, your HR, may consider that a no-go. I can tell you that we have not really had that issue. I don't know that we've had a candidate apply that we actually haven't been able to hire for any prior legal challenges, but it is something to think about. The cons, additionally, funding has been insecure. I mean, there's no may be insecure. I've kind of relied on both, hospital leadership kind of being committed to this model, but also gone around and tried to get any grant that I can to help cover salaries to the best extent I can. I think at this point, we've had them for 4.5 years. Everybody kind of feels like they're a fixture in our ED, and I feel like there would be outrage, if anyone tried to change their status, within our system. But it's been, hanging over my head, frankly, for the last 4.5 years, and worrying about making sure that nobody is going to make some irrational decision about the value of their that they provide to our ED. Additionally, a con would be that there's no shared knowledge from floating between sites and communities. So if you have a PIHP employed or contracted peer, they may be going to different sites and can kind of share best practices with you. As opposed to this is kind of more of the in-house model where our way is the way, and they might not be able to necessarily make quality improvement suggestions on experiences they've had other places. So the exciting news that came down from the state that's in the state budget that has passed for October 1st is that there is funding to support peer recovery coaches in hospitals specifically, so hospital-based peer recovery for substance use disorder, and kind of explaining that these are specifically trained individuals, and that Michigan is joining more than 38 other states to provide this needed care model. And it's actually a significant amount of money, $8.3 million line item budget in the Michigan state budget. However, despite the fact that this October 1st is coming quickly, we still have almost zero details of how the funding will be provided. Is this going to be in like chunks of funds, like grants out to hospitals, or is this going to be in some type of reimbursement model where you submit documentation, and the downsides of that is usually this is not high dollar billing. So, the cost of doing the billing might exceed the amount that you're being reimbursed on. We also don't know if this is going to be a multi-year item in the Michigan state budget, or how these funds might shift over time to ensure that peer recovery is continuously covered in the hospital setting, as opposed to the current model that is the PIHP model. Anything else you want to add on that one, Nick? It's exciting news. We just don't have the details yet, unfortunately.
Yep.
We're hoping to have it by now.
And the details are the only thing that matter.
That's correct. Yeah. So I'm particularly concerned that if this would be a 1-year line item, that folks, by the time they got their leadership to be convinced that this is something that we should do, and actually go through the HR process and the hiring, it's going to take a few months at a minimum, that the funding would go away, and then people that were brought on would be just cut loose due to lack of continuing funding. And to me, that's just hopefully there's no short-sighted views like that, because it won't really help. The great value that I think our peer recovery, a hospital-based, hospital-employed peer recovery, which can be translated into the community provided PIHP contracted peers. So this can happen similarly, is that you are able to, if you do triage screening, the way we have things set up is everybody who comes through the ED, I'll just jump forward one slide, is asked substance use questions, and both alcohol and drug use. And if they screen positive, what that does is our peer coaches actually have a track board, just like we all do. We use Epic, and theirs is titled, the column is titled SBIRT. And so if they've screened positive for substance use, they get a red check in their this column here. So that is visible by the providers, but actually populates the track board that the peer coaches work off of. And as long as the patient is not unstable or they're not acutely psychotic, they have free reign to go and talk to the patients without being prompted by a provider. And sometimes, and oftentimes, the provider won't even know that they've screened positive. They might be coming in for a completely different reason. And so they'll talk to the patient, identify their state of change, try to do motivational interviewing, brief interventions. And if a patient does have, say, an opioid use disorder, and they need to, or they're interested in starting treatment, or they're starting to go into withdrawal, or they might go into withdrawal in the next couple hours, they'll come and talk to the doc and say, hey, this is somebody that probably could benefit from bupe. I'm going to set them up with outpatient treatment, or they want to go inpatient, or whatever the case may be. And so it really all keeps our peers busy to the point where we actually removed marijuana as one of the drug use screening questions, because it was, kind of just like clogging their board, and we don't have a ton of resources for marijuana use. And people can debate the harmful effects of it, but with opioids, obviously it's our number one priority. The peers will prioritize those that are in withdrawal or overdosed, and then probably the greatest volume of patients that are screening positive for substance use is for alcohol, and there's obviously a ton of opportunity for intervention there. So again, if you've got them, they don't have to be hospital employed. However, it makes it much easier to integrate them in the EMR. You can get them EMR access even as outside contracted PIHP peers, and it's just a little bit more complicated, and we'll talk about the pros and cons of that situation, but allows you to track documentation, linkage to care, at least to the initial linkage to care rates, and quantify how many interventions they're actually making. And I'll take just a second or two more on this slide to just go slowly through what all of our triage nurses ask of every patient. And they have like kind of some easy outs in here. So if the patient comes in and, is not answering questions or appears to be intoxicated or overdosed, they don't have to sit there and try to go through all these. They just click one of these two boxes, and or if the patient refuses, then all these questions go away. The triage nurse, who is extremely busy, and we are very sensitive to the fact that this is a very busy situation. However, our poor triage nurses have to ask about travel history, and this is all mandated JCO required questionnaires, and I really wonder how many MERS patients we've ever had, or the Middle East respiratory syndrome patients we've ever had that we've asked questions for, as opposed to our substance use questions. I feel like are very relevant to our patient population and oftentimes more useful. So depending, you can set your audit C cutoff score at whatever you want. Some would argue that a lower cutoff score of like an audit C of 4, this is for alcohol use disorder screening, it would be, a cutoff of 4 or more would be considered a positive screen. We use 7, and that keeps our track board manageable for our peers. But like I said, some people would argue that if you really want to do the true work of that peers do, which is kind of starting to screen and do motivational interviewing and brief interventions before substance use becomes a severe problem, maybe you should have a lower cutoff score for some of these. And if the patient used any drug at all, essentially, did you use any, like I said, it currently says smoke marijuana, but we removed that from this since I've made this slide. So have you used any drug, street drug, or non-prescription pain medication? If so, what? And they just click a box here. If they're suspected overdose, then there's a little button they can click as well. So again, that populates the track board for us and allows the peers to work fairly independently in the ED, and then come and identify patients that need help to the providers. And again, we rely on them to do the work of getting them set up, and we do the medical part. Oh yeah, I'll do a COWS score on the patient if they're in withdrawal, and I'll give them the medication, but they're going to do the hard work of figuring out what's the best place for them to go after they leave the ED. So that's kind of the hospital employed model. Again, I'm biased. I think it gives you more patient touches. But the far more common model that is prevalent throughout the state, and frankly has been more sustainable, is using the PIHP, or the prepaid inpatient health plan contracted peer recovery organizations. So there's tons of them in Detroit. Team Wellness, blinking. We have Detroit Recovery Project. What are some of your organizations out in Grand Rapids, Nick?
We have Red Project that helps with a variety of things, but also houses peer recovery
Yeah,
coaches.
I know out in Jackson is the home of New Vision. Up in Macomb County, they have CARE. And so there are multiple of these organizations. If you're not sure who they might be, you just contact the local PIHP and they will let you know who's available, and they kind of work with organizations. I think Detroit Receiving works with Sobriety House. So Sobriety House is a contracted organization with the Detroit Wayne Integrated Health Network, PIHP, and they actually have the peers embedded at Detroit Receiving, and I think Sinai Grace Hospital as well. So the big time pros is you don't have to hire these people. The community organization is the one that handles that. So that's like one kind of huge thing that's checked off. The funding is significantly more secure. The organization will do kind of the math on how many patients that their peers need to see. They have to do their own internal documentation in order, because they can actually bill the PIHP. The community organization bills the PIHP and gets funds that are set aside for this specific pathway, essentially. And the peers may go from site to site, so they may have added value of knowledge from multiple sites, especially if they're not embedded at one hospital, or they may have go to different hospitals during the course of a year or two or three for periods of time commitments, and have some experience at other places. The con would be that the funding pathway, I don't know if I tried to explain it the best I could, but it's convoluted. You have an organization that's contracted with the local authority, and then they bill in a kind of a strange way. And I can tell you that the peer that we have at our Wyandotte Hospital, and I think out at the Jackson site too, for Henry Ford, these are PIHP contracted organizations. So they need to document in their EMR in order to bill, but we'd also like them to document in our EMR so we can track. And so essentially they double document. And if you do have them integrated into your EMR, you do have obviously the lack of control over who's coming, because that's you're not going to be necessarily interviewing those people. You suppose obviously if someone's not working out, you can let people know, but you are not going to be probably the one interviewing the person and kind of trying to determine the fit for your department. There can be some legal restrictions. Fortunately, Henry Ford has been pretty lenient on getting these outside entities the EMR access and the ability to document. If you don't have somebody that's embedded in your ED, you may be subject to long response times. A lot of these organizations kind of pride themselves on being available like within 60 minutes or 2 hours tops. So I've not heard bad things about that, but sometimes I wonder, with just like any organization and staffing, I feel like there's going to be gaps. So you might not have the reliable service that you would expect if you had them hired into your own facility.
I've been in two organizations with peer recovery coaches, and at Trinity we had hospital based for a brief period of time, and then and Flint we had PHP contracted through New Paths, and I like both, but having them through the PHP was so nice that they would visit multiple hospitals. At the time, we didn't have great documentation sharing between the different hospitals in Genesee County, so it's hard to see where patients have been. Maybe that's improved since I've been there, but um, the peer recovery coach would walk in and just say, "Oh yeah, I saw this person yesterday." Like they knew exactly what was going on. But to me, it seemed like that was the first time they've been seen. So there's just a lot of benefit to having someone that kind of bounces around from hospital to hospital if you're in an urban center, because patients also go from hospital to hospital.
Yeah, that's a good point. Yeah, Nick kind of added that to the slides here because that's not something that I have any experience with, but I could see that as definitely a value that you have. Somebody that knows the walls outside of your own and the patients outside of your own too, because there's like almost some continuity of care, unfortunately, or fortunately, depending on how you look at
Yeah.
it, because those
It,
relationships are important.
it would be funny sometimes the recovery coach would say, this patient usually goes to hospital B. I wonder why they're here today. So they would they would know that something has changed in the patient's routine because they would always see them in the other hospital. And so it was just kind of interesting to have their insight.
Yeah, absolutely. So the other unique staffing model that we have in Michigan is the Families Against Narcotic. I put other nonprofit entities. I'm sure there are some. Essentially, they're not doing billing. They just kind of are grant funded, and FAN in particular is a line item on Michigan state budget annually. We work with them. We provide them as a resource for some of our Henry Ford EDs as well, kind of more on an on-call basis. And one of the questions I had for them when we were kind of setting up the structure is like, how do I know that you're not going to go away next year? And I would say that they have probably the best or longest track record in the state. They they are not kind of I guess held by county lines, so that becomes a big deal sometimes when a patient's in your ED, which county they live in, because that defines because those PIHPs are very much county based to some extent. Depending on what county they live on, kind of dictates what treatment options. Yesterday, I was working in the ED, and we had a patient that wanted to go inpatient for opioid use disorder, and he lived in Macomb County. And so we have multiple organizations locally in Detroit and Wayne County. The only one that they were able to work with up in Macomb County didn't have a bed until the next day, unfortunately. So, the patient had some moderate to severe withdrawal. So we ended up just keeping him to manage his withdrawal symptoms, and kind of worked out better for him. But ideally, you're getting your patients out the same day or even within a few hours. That's kind of the norm. So again, though, from the pros side, you're not having to deal with any of the onboarding, and the funding in the case of FAN is secure. Again, the added knowledge of multiple sites that Nick spoke of from some of his peers' experiences in Genesee County. And again, the FAN peer recovery coaches don't have to bill for their services. So that's like one, fairly nice non-encumberment to have. Again, the cons are similar to your PIHP contracted coaches, that you don't necessarily have control of the schedule or the personnel. And there are some of the same restrictions to EMR access you will have. And then the variable response times, although I put that in as a question mark because I don't know that that's actually an issue, and I've actually not heard that's an issue, but I could see that it would be an issue. Any other experience you've had with FAN, Nick? I mean, obviously I think they're a great organization. They're getting involved in a lot of different ways now with opioid quick response teams as well coming up here. So I just think they are a good organization. They're definitely worth a mention. And sometimes they are the easiest to work with because of the lack of billing issues that they have.
In Kent County and Genesee County, other entities were more prominent, but it seems like they're pretty active over on the southeast side.
Yep, yeah, I would agree. Yeah, they're starting to expand out, probably as far west as Jackson, but and I don't know about as far north as Flint, but yeah, they're heavily concentrated their work so far in Southeast Michigan. So we're starting to get to the end here. I don't know if there were any comments or questions along the way. I would invite them as we kind of wrap up the ideas here, but hopefully we focused, on the peer recovery coach model enough for you guys to get a feel for, what you might be looking for if you're going to start a peer recovery program, whether it be hospital employed or via the PIHPs that are available. But I would say some of the barriers and pitfalls to be aware of is, like I mentioned before, reliance on grant funding for peer coaches. I've seen that happen at one of our Henry Ford EDs where grant funding went away, and the hospital leadership there just decided to stop the program and went to the PIHP contracted model. It took about a year, frankly, though. They went from having full service peer recovery coaches that were employees, and then by the time they got things working, I think it was probably over a year. So not great for the docs, who get used to a certain service for the patients, and then that's gone. Still personally a little bitter about that, but I'll reserve further comment. And You also, one of the things that we're always looking at is how well we are compensating our peers, and if there is kind of a windfall in terms of financial compensation for peer recovery services. You have to kind of look at the market, and we've actually lost one of our peers that we had from the beginning that we had with Stan to the local Detroit Wayne Integrated Health Network for pay alone. So, that creates frustrations and had to go to HR and complain and whine, and eventually we get something. But that's definitely a pitfall or a barrier to make sure if you are going to employ somebody to make sure that you're at least market competitive. Um, I
I
think,
feel
yeah, go
my
ahead, Nick. Yep.
oh, I was just going to add a comment, and I think the only audience would be if there's someone from the state here. But um, we talked about how all the great things peers do in the department in the hospital, and then they break down stigma. The other thing that these programs do is they give a potentially rewarding and emotionally rewarding, but also a good, hopefully a good paying job to someone who has struggled and has opioid use disorder and is now in recovery, and they're doing good things for their peers. Um, and so I think it's important that we give them a livable wage, and that, like, what better state money could be spent than something like this, where you're supporting someone who's gone through all this. They're helping, they're giving back to the community and breaking down stigma and providing medical care. Um, and so, yeah, it's just, I don't know. The argument would be that we need to pay them enough.
Yeah, absolutely. So I like I mentioned, we lost one of our peers due to not being competitive, and so just I think just something to think about. You got to do a little bit of a market analysis. And it's not hard. I mean, Google, what the local folks are paying, and make sure that you're competitive, because you don't want to go through the process of bringing somebody in just to find out that they're, not going to be happy with their wage, and then end up going somewhere else after you've taken the time to train them and integrate them. Um, my big pitch for hospital-based peer recovery is the ability to integrate. You're integrating with their employees. There's some stigma involved in othering. If you've got every single service available in your hospital, like orthopedics, physical therapy, speech, obviously respiratory, but hey, you got a substance use disorder. Well, we're gonna call this other outside organization, and they're gonna come and see you because that's different. No, peer recovery is part of the hospital system, the process, and so there's some stigma related issues there, but there's also big time efficiency related issues with not having integrated peer coaches. And what are they doing with their time? If they can actually look at the trackboard and see who's screened positive on their own without being told what to do, that allows them to be much more effective in their outreach to patients and patient touches, as I like to say, in order to plant seeds for those that aren't ready, but also to do the hard work of identifying those with SUD, doing the motivational interviewing, the brief encounters, bringing them to the level of the physician if needed for medication, and their linkage to resources in the community. And one other issue that you may have is unreliable community partners. Frankly, I've actually not run into this, although I'm sure our peers who are the experts, have places that they prefer over others. And so I know that they have some people that, they just make it easy on them, in order to get patients in, and they get good reviews from their patients that have gone there. And so just something to keep in mind, you know, talk to your peers, find out who they like to work with, and understanding who is going to provide the most regular and consistent support. So that's like a key thing as well, right? We want to know that our patients are going somewhere that they're not going to show up and there's nobody there to take care of them. So it's not been a huge issue, but like I said, I know there are probably some that are better than others out there. So in conclusion, I just like to mention again that addiction is a disease and should be treated as such. And, I can't state enough that I think peer recovery is such a key cog. There's research to support it. There's anecdotal evidence. And then, I personally find it really rewarding. When I first got into more addiction medicine work, back in 2019, 2020, I was kind of skeptical of the whole process, and still having some internal stigma, like, oh, I'm going to be in charge of some folks that have substance use disorders. Great, but I can't say enough about how my opinion has gone 180 degrees in the opposite direction on that, because I really find these individuals motivating to me to take care of other patients, because I can see what they can be, and then I say, you can be like Stan, or you can be like Jim, or you can be like Dave, and I actually have a living, breathing model of success to share with them. So I really, these folks inspire me personally. I really enjoy working with them. Um, Additionally, the opportunities to integrate, I think I've beat this one to death, but you can see more patients, and I think that's good all around. And the peer coaches and the warm handoffs really are the crucial the way to go. And we have a whole additional discussion on warm handoffs coming up next Monday, and what that means, and what is a warm handoff in particular. So I won't get into that too much, but that's been shown that you're not just telling a patient, here's a phone number to call. No, you're taking the extra step. Here's the appointment. This is where you're going to be, and this is the people you're going to see, and you're going to go from here. And so we're starting you in the ED, but you have a continuing place to go, and you know where to go, you know when to go. And I think those have shown to be really effective in keeping people engaged in treatment, as opposed to, here's some Zofran for nausea, and a phone number to call, and best of luck to you. So sorry you don't have a house or a car. So I think navigating these social determinants and have been key in keeping people engaged and allowing them to continue in their recovery. Anything else you want to add there, Nick?
No, all well said. You're not the only one who finds these peer recovery coaches motivating. I previously cited that study that talked about all of the extra things that the peer recovery coaches do. But one thing I didn't mention is that in this site, they noticed that when they started the peer recovery coach, they had a 575% increase in Narcan kit distribution and a 90% increase in buprenorphine prescribing. So yeah, they motivate the patients to go to their appointments, but they do also work the other way, and they motivate providers to kind of step up and give the patients the care that we think is best.
Yeah, we have some links here for other trainings that you might be interested in, or the previous lectures that we've given, and some of the tools that are available. California Bridge, if you just Google them, as an outstanding resource for all things opioid use disorder. But here's our contact information as well. We're happy to talk to you, reach out, help you, along the way in terms of peer recovery or any of the steps involved in making an effective MOUD program, and doing some of the quality improvement and quality assurance that's related to that as well. And then sometimes I like to hear from you all too, just about the way you're doing things, because over the course of time, I've definitely taken ideas from other places and implemented them at our facility as well. So by no means are we doing it the best and the brightest. And we've just been doing it the longest that I'm aware of in terms of hospital-based peer recovery at Henry Ford. So I will end and then stop sharing.